Good evening. It's my great pleasure to present a very interesting and important topic, cardiogenic shock. We'll talk about new concepts. We'll talk about some new data on prognostication and most importantly, how to manage this very, very critical condition. Let's start with classification of cardiogenic shock. What is new in this area is there has been a lot of discussion in the last few years on how to classify cardiogenic shock, and we'll talk about some new concepts. If you remember, the definition of cardiogenic shock has been highly variable, both in clinical practice and in the trials that have been done in this area. And in 2019, the Society of Cardiac Angiography and Interventions came up with their classification, which mainly concentrated on diagnostic categories and severity of the disease. Over the next few years, this classification was validated. Its prognostic significance was shown to be very robust. And then it started to materialize. In 2022, just a few months ago, the society refined this a little better to include some new nuances. And hopefully using these kind of pathways, we may have new thinking in the form of agnostic diagnostics. I'll talk about this a little later, and more importantly, utility in clinical trials. And then the goal is probably in the next 10 years or so, we'll be able to find physiologic categories that allow us to find specific treatment paradigms. Exciting time. It's good to have standardized the whole concept and the field. So how did this evolve? It came from the concepts that there is a pre-cardiogenic shock stage, there's a cardiogenic shock stage, and then there's a stage in cardiogenic shock which is so far advanced that a lot of our therapies become refractory or futile. And this was broken down into two things. There were two early stages. One was at risk at a time when the blood pressure and perfusions were okay. There was a beginning of shock where there was hypotension. You had classic shock where hypoperfusion came up. A concept that's coming up is cardiac power. We'll talk about that later. And then, of course, you had deteriorating shocks. And as you progress through this, lactate increase, which is a sign of hypoperfusion, became more and more prominent. At the bedside, you could classify it as warm, dry, warm, wet, cold, dry, cold, wet. These are concepts which were there before, but now they have been crystallized into the thinking. However, even today, there's still variable definitions of cardiogenic shock, even after the SKY classification. Here are four major groups that work in this area, and you can see they continue to use different. The Mayo Clinic uses hypoperfusion or acute kidney injury. The Hamburg groups again use one or the other, and the CS working groups uses a presence of one or more vasoactive therapies. So it's still not completely standardized, but hopefully going forward, this will change. Some of the limitations of the classification were as follows. For one, it showed you a nice progression of mortality as we go from stage A, B, C, D, E, both in MI and heart failure, but it doesn't use a lot of congestion variables. And as you can see from this paper from Thayer et al., congestion plays a big role. If you plot right atrial pressure and pulmonary capillary wedge pressure, you can classify it into four groups. Euvolemic, LV predominant, RV predominant of biventricular failure. And as you can see, both in acute MI and heart failure, there is a progressive increase in outcomes, worsening outcomes as congestion increases. So this is a parameter that is not often seen in this SKY classification, but this is something to keep in mind. What did the 2022 modified classification bring in? It brought a three-axis model. Instead of just the severity, it emphasized risk modifiers, phenotyping the etiology. It provided more granular shock categories and best risk modifiers, especially how to define cardiac arrest. Here is a three-axis model that they talk about, and if you end up in a bedside, you can have a very comprehensive profiling using hemodynamics, end organ perfusion, hemodynamic support, and how the patient is responding to therapy. So this is what they come up with. They again use the same pyramidal classification like before, A, B, C, D, E, but now they have been a little more granular, especially with cardiac arrest, which is common in nearly half of the patients in the stage E. How do the mortalities rate at these different classification? There's a very nice separation. As you go higher, the mortality becomes higher and higher. This has been shown repeatedly. What about using some other methods like an agnostic classification? If you remember, the SKY classification uses fixed parameters. How about you throw in a bunch of parameters that are collected during the course of a cardiogenic shock patient and try to classify it by cluster relations, where you see what parameters group together in what kind of patients. You are, in this paper from Zweck et al., they ended up with three groups. There was a cluster 1, cluster 2, cluster 3, and each of these clusters you can see have very specific characteristics, and these seem to be predicting prognosis. So here is an example of cluster 1 in red, cluster 2 in green, cluster 3 in blue, and you can see in a whole bunch of hemodynamic parameters, these clusters behave differently. Similarly, for metabolic parameters, they behave differently. Going up outwards means high abnormality, going inside is lower numbers. And as you can see, they separate nicely. And these were called as non-congested cardiorenal and cardiometabolic forms of cardiogenic shock. And as you can see, there's a nice separation of mortality, in hospital mortality. So in future, machine learning may allow us to classify patients of cardiogenic shock based on these clusters, rather than just using the traditional blood pressure and organ perfusion or congestion phenotypes. And here you can see, as the phenotype progresses from 1 to 3, you end up in higher shock stages, and the mortality also increases. So that's something for the future. How about cardiac arrest? Although we think cardiac arrest separate from cardiogenic shock, it is actually a big component. It is very common in cardiogenic shock, especially in the stage E patients. And also 2/3 of patients with cardiac arrest need vasopressor therapy. The outcomes obviously are worse in patients with cardiac arrest compared to those without, and prognosis depends often on cerebral and multi-organ injury and not treatment of the heart alone. One of the biggest advances in this area is using ECPR, that is ECMO-facilitated resuscitation. Early ECMO improves the substrate for advanced therapies. It normalizes systemic and coronary perfusion. It helps you stabilize metabolic changes, and it allows you time to decide what to do and triage the patient and optimally manage it. Lots of centers are doing this. One of the biggest centers in this area is my university, the University of Minnesota. And here are two publications. One, so using the University of Minnesota ECPR protocol, in the last publication a few years ago, 160 patients were in cardiac shock and cardiac arrest were transported with ECMO-directed hemodynamic stabilization. And they were compared to a previously published randomized trial of amiodarone in cardiac arrest. And it showed that you have a favorable survival with ECMO-supported CPR compared to non-ECMO-supported CPR. That was not randomized, but here is the first trial published in the Lancet by one of my colleagues, Dimitri Yiannopoulos, who did the arrest trial. And here are the inclusion criteria out of hospital cardiac arrest, VFBT, and who were being provided mechanical CPR. They were transferred within less than 30 minutes to a cath lab, were put on ECMO. Here are the variables where ECMO was or what not used. And if you compare the ECMO group with the standard ACLS therapy, you can see the ECMO group has far better survival. If you look at neurological outcomes, whether it is modified Rankin score or cerebral perfusion category, performance category, you can see uniformly ECMO-supported patients improved, whereas standard therapies did not. This is a big advance. It's expensive, it's resource intensive, but that is supposed to be a game changer. Here are the consensus criteria from various organizations about where you should use ECPR for out of hospital cardiac arrest. We can discuss this in the question answer session further. What else is there? One of the things to remember is despite all this excitement, the evidence base for cardiogenic shock is very, very thin. There are many guidelines, but there is little evidence of utility. Here are 4 or 5 different guidelines, all in the last few years, and all of these have been written with very little randomized trial data. Here are the 4 major randomized trials in this area, and you can see they were anywhere from 192 to 706 patients, small trials. Here are the consensus criteria among various major society guidelines. They keep moving here and there. 2 or 3 things to note. Most of these are old criteria, old guidelines. They have not been updated with new data. As randomized trials keep coming, things keep changing. For example, LVS's device has moved from 2B to 2A, while intra-aortic balloon pump has moved from 2A to 3. Small changes, but a lot of this is expert opinion. There is a big push for shock units, dedicated shock teams, shock units, which are supposed to manage these in very, very rigorous protocols. Again, resource intensive protocol. Here is an example of a protocol from Bill O'Neill's group in Detroit, where they have a very aggressive way of handling patients with cardiogenic shock. And in observational, non-randomized trial, they seem to have a huge benefit in even in shock C and D stages compared to the IABP shock 2 trial, where 60% were alive at 30 days and 42% at 1 year. Here they had 77% alive at 30 days and 62 at 1 year. And even in the sickest patients, they had a reasonably good survival. Whether this will stand the scrutiny of randomization, we don't know, but that's something that is coming down the road. Then, of course, the RAND model looked at the evidence base of all our guidelines, and it looks like a lot of things that we do may have uncertain category recommendations, but a majority of the guidelines seem to be in green, suggesting they are appropriate to be used. Central venous and arterial line institution is uncertain in this analysis, but it is rare that you won't find a cardiogenic shock with an A-line insertion or a CVP. What else do we know? How about evidence-based in inotropes and mechanical circulatory support devices? As you can see here from this thing, in randomized trials, the predominant criteria that has been used is blood pressure. End organ perfusion and cardiac function have been used to a lesser extent, and hemodynamic parameters of congestion have been used even less often. Not surprisingly, a lot of the therapies, both inotropic medicines and mechanical circulatory devices, have been focusing on maintaining a blood pressure, mean arterial pressure, and perfusion. So what is the evidence base we have? In chronic heart failure, we know inotropes increase mortality. However, in cardiogenic shock, this question has not been very clearly answered, and there is a fair amount of uncertainty on what's the effect on mortality. In propensity analysis, 2 things come out. One, that dopamine is worse compared to all other inotropic vasoactive agents. Second, combining a vasopressor and an inodilator like dobutamine, levosimendan, or a PD3 inhibitor seems to be better. There's a randomized trial coming in future called DOREMI 2, which tries to test whether inotropes versus placebo. This was thought to be not feasible till now, but this trial may do it. And then, of course, mechanical support therapy with or without inotropy may be the next thing to investigate. What do we know about this? Here is the study which is showing compared to norepinephrine, dopamine has a worse outcome, especially in cardiogenic shock. And so it is not a favored drug anymore. Norepinephrine is favored over that. And when you add a inodilator, you can see it performs better than not and just a pure vasoconstrictor. So that is all the data that we have. There is also some evidence that some of the inotropes may have adverse prognostic effects in a slightly longer term. How about milrinone versus dobutamine? Both are inodilators. Milrinone is 10 times more expensive than dopamine, and it is used a lot in our settings. But this trial, which just came out recently, shows that there's really no difference, whether in urine output or lactate or primary outcome or death from any cause. So actually it's a wash. So dobutamine is as good as milrinone. How about mechanical cardiac support? as you can see, IABP use has been coming down, whereas mechanical intravascular microaxial LVADs like Impella, etc., are increasing significantly. And here you can see there is a distribution of, in a big shock center, what are the various things. Only 25% of the patients don't have mechanical support. IABP is still used very commonly, and as you go into higher shock stages, mechanical support, either in form of Impella or ECMO, becomes more and more common. With all this excitement and new technology, what is the evidence that this all works? Here is a guideline from Tim Henry's major statement in Circulation last year: when to use Impella or when to use VA ECMO, depending whether it's LV failure, RV failure, or refractory respiratory failure. But what is the data behind this? Here is a very recent analysis just a month ago, which looked at outcomes, whether you use traditional support or you use advanced support, LVSS devices, mainly percutaneous ones. And surprisingly, you will find that whether you see death in index hospitalization death at a month or a year, people getting very aggressive mechanical support seems to do poorly. And this is also reflected in high bleeding rates and need for kidney replacement therapy. So even though we are all very excited and we think these are major advances, data seems to say that this may not be true. And this is happening in more than one observational study. We obviously have to await a randomized trial. The small randomized trials that have been attempted so far have not been very robust, and they show kind of modest significance for using these things. And here is the survival curve. You can see people with intravascular microaxial LVAD seem to do worse, and not by a small margin, but by a significant margin. So this is something to keep in mind. So what is the summary of this field? Three major advances. ECMO-supported CPR is probably the big thing. As far as inotropic therapy is concerned, there doesn't seem to be a big difference between what you use, especially if you use a combination of a vasopressor and an inodilator. That seems to be the best combination. Mechanical circulatory support devices are being used a lot, but we still don't know what is the exact role for them or how they affect mortality and morbidity. We also have to remember a lot of data in this is expert opinion based with very heterogeneous subsets, and that may be one reason why we don't have very clear data on who benefits or not. Defining cardiogenic shock very methodically, like the SCAI classification, is the first step to realizing better therapies. Early detection and comprehensive phenotyping may be very crucial. We need predictive analytics on finding the best subsets who will benefit, as well as one of the things that coming up very well is where will the therapy be futile? Futility is very important. There are some new randomized trials on the horizon, and we will have to await all that to define this field further. Thank you very much.